Thank you, Andrea. Last but by certainly no means least, my very great pleasure to introduce Dr. Susan Shenoi from Seattle Children's. She'll be talking to us today on the power of biologics in cutting-edge juvenile myositis treatment plans. Dr. Shenoi is a pediatric rheumatologist and professor in the Division of Rheumatology, Department of Pediatrics at Seattle Children's Hospital. She's also the clinical director in the Division of Rheumatology and director of the Seattle CureJM Myositis Center of Excellence. It's worthwhile pointing out before Susan starts her talk that she really stepped into the breach with our Center of Excellence. She had some very big shoes to fill as Dr. Stevens moved on to the pharma industry, and I know I speak on behalf of the foundation. The work that she has done at Seattle is absolutely outstanding. She made these difficult shoes to fill. She turned them into a pair of on-cloud, fantastic Olympic quality running shoes. The work that she's done in the clinic and with the kids in the area is just amazing, to the extent that within the foundation, we often hear, if you are in Washington State and your kid's not doing well with JAM, it probably just means you haven't seen Susan yet. So we're all extremely happy with how she's managing the Seattle COE. Her research interests span epidemiology of pediatric rheumatologic diseases with a particular focus on environmental risk factors, juvenile idiopathic arthritis and juvenile myositis. Dr. Shenoi is passionate about increasing awareness and improving outcomes in pediatric autoimmune diseases. And I would invite Dr. Shenoi to talk to us today about the power of biologics in cutting-edge juvenile myositis treatment plans. Susan, over to you.
Thank you so much, Andrew, for that kind introduction, and thank you for the invitation. I'm humbled by what you said, and I have to say that my first love always has been juvenile arthritis, but boy, did CureJM and Ann Stevens entice me into having an affair with juvenile myositis, which I've really enjoyed. So I am going to be talking about the power of biologics in juvenile myositis today. These are my disclosures. Most significant of which is the Seattle Juvenile Myositis Center of Excellence receives funding from the CureJM Foundation, which we are immensely grateful for. And I will reference off-label use of medications as there are no FDA-approved medications in juvenile myositis. So this is one of my favorite quotes from Rudyard Kipling. I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when, and how and where and who. So I'm going to use 3 of these 6 honest serving men today to frame my discussion around biologics in juvenile myositis. We're going to look at what is the current data that supports the use of biologics in juvenile myositis, where along the treatment algorithms do BD-MARDs stand, and which BD-MARDs are on the horizon. I'm also going to review select adult inflammatory myositis data, and I will not belabor mechanism of action or side effects of BD-MARDs as this crowd potentially is well versed with that. I will also not discuss JAK inhibitors as Stacy Tarvin gave a fantastic talk at the last summit on these. So let's dive into the first question. What is the current data that supports the use of BD-MARDs in juvenile myositis? IVIG, lo and behold, is a biologic agent. I'm not going to belabor this, but IVIG works. It works really well. Use it often. It's considered standard of care for most juvenile dermatomyositis treatment plans. And through the PRODERM study, it was officially approved by the FDA for the treatment of adult dermatomyositis. I will point out that in the PRODERM study, which was a randomized controlled trial with IVIG and placebo, they did notice about 6% of thromboembolic events. And they had to adjudicate this and modify their protocol along the trial, reducing and slowing the rate of infusion for IVIG, which then reduced the incidence of these thromboembolic events. Let's look at rituximab, which is an anti-CD20 agent. So the best data for rituximab in juvenile myositis really comes from the rituximab in myositis or RHIM trial. This was a randomized controlled study that randomized patients to receive rituximab either early at week 0 or late at week 8. They enrolled 200 patients, 48 of which had juvenile myositis, and the primary endpoint was time to achieve the IMAX definition of improvement between the early and the late groups. And as you can see on this graph here, there was significant overlap showing that this trial did not actually meet its primary endpoint, likely because the investigators underestimated how long rituximab would take, and they underestimated how high the placebo effect would be, which is a burden with several of our trials in rheumatology. However, what's encouraging is that 83% of patients met the definition of improvement at 44 weeks, telling us that rituximab does indeed work. Post-hoc analysis of the RHIM trial data showed that juvenile patients with dermatomyositis had a shorter time to improvement compared to adults, and patients that had autoantibody positive disease had a shorter time to improvement as compared to those that did not have autoantibodies. Rohit Agarwal and his group also showed that anti-Jo1, TIF1 gamma, and MI2 levels actually decreased with rituximab, and this decrease correlated with disease activity. Unfortunately, levels of antibody titers are not available in clinical practice yet, but they are only available in research settings. Recital trial is a recently published trial that was centered in the UK across 11 centers. And this trial looked at determining superiority of rituximab compared to IV cyclophosphamide in adult patients that had severe progressive interstitial lung disease that was associated with either scleroderma, inflammatory myositis, or mixed connective tissue disease. They gave patients rituximab 2 doses, 2 weeks apart, or 6 doses of IV monthly cyclophosphamide. The primary endpoint for this study in patients with severe ILD was a change in the forced vital capacity at 24 weeks. And the study had several secondary endpoints as listed here, including safety and tolerability, steroid exposure, FVC change at 48 weeks, patient-reported quality of life measures, and cost-effectiveness of the 2 medications. It's impressive that they enrolled a little over 100 patients with severe ILD, the mean age of whom was 56 years, and about 45% of those patients had inflammatory myositis. While this trial did not meet its primary endpoint, that means rituximab was not actually deemed superior to cyclophosphamide. Both these drugs did improve FVC at 24 weeks, telling us that they work in ILD. Patients that were on rituximab, however, had fewer side effects as compared to cyclophosphamide. They had less steroid exposure, as shown in the graph here, and overall rituximab was thought to be more cost-effective. I also want to point towards the ACR guidelines for interstitial lung disease management that were presented at the ACR Convergence meeting last year and recently published. They have a section on management of ILD as it relates to myositis. And as you can see here on the left-hand side, for first-line therapy for myositis-associated ILD, rituximab is listed as one of the agents. For patients that have rapidly progressive ILD with MDA5 positive disease, the ACR guidelines really recommend triple therapy that is a combination of IV steroids and 2 additional therapies as listed here, including rituximab, IVIG, cyclophosphamide, MMF, tacrolimus, or JAK inhibitors. Moving on, let's look at abatacept. So the best data for abatacept comes from the AID trial, which was conducted by Rodolfo Curiel and his group. This was a 24-week open-label trial looking at the efficacy and safety of abatacept in 10 patients with juvenile dermatomyositis. The mean age of the patients was 12 years, and the mean duration was about 2.7 years. The primary endpoint of this study was also the IMAX definition of improvement at 24 weeks. And in the figure here to the right, each colored line represents a single individual patient in the study. And as you can see, all of these lines are moving up with the exception of one line, stating that 9 out of 10 patients really met the primary endpoint. Not surprisingly, abatacept was shown to be steroid sparing, and patients were able to reduce their prednisone dose by almost 40%. And as Adam presented earlier, about 4 patients had severe adverse events, including worsening ILD. worsening calcinosis, and compression fractures. Let's look at other biologic agents, so TNF inhibitors and other agents. When I looked for the data, it looked a little bit like this. So that's Snoop Dogg's expression, and looking at Simone Biles at the Olympics. So the data is sparse, it's little, it's all over the map. This is a recent systematic literature review done by Cerner et al., and they list all the different TNF inhibitors that have been used in juvenile myositis patients. As you can see, it's infliximab, etanercept, adalimumab, and there's actually sparse reports of golimumab as well. In this column here, you can see the responses. Again, some showed improvement, some did not show improvement. As Adam mentioned, sometimes infliximab and adalimumab can be used in calcinosis, including the most recent report that he presented of infliximab being used locally in calcinotic lesions. And then looking at other biologics, the data really is sparse. So there are some publications of anti-IL-1 agents, such as anakinra, being used, tocilizumab, which is an IL-6 blocker. Both these have been tried in macrophage activation syndrome associated with dermatomyositis or juvenile myositis. And then there's single individual case reports of bortezomib, which is a proteasome inhibitor, ustekinumab, which is an IL-12/23 agent, and eculizumab, which is a complement blocker. So let's look at the next question. Where along the treatment algorithms do BT-MART stand for juvenile myositis? Cara has published several consensus treatment plans, one of which is around biologic DMARDs that was published recently. Before we dive into these consensus treatment plans, I really want to remind people that consensus treatment plans are not the same as guidelines. Consensus treatment plans are where you have a group of people that comes to consensus using consensus methodologies such as nominal group technique on how to treat certain rare diseases, particularly where there's a lot of variability in treatment. So these really reflect expert opinion and real-world experiences. As I mentioned, there are 5 CTPs through CARA. 2 CTPs are for skin disease and juvenile dermatomyositis, and in both of these CTPs, biologics do not feature as part of the consensus treatment plans. 2 CTPs are for management of moderate to severe dermatomyositis for the initial treatment, where there's A, B, and C treatment plans that is a combination of methotrexate, steroids, and/or IVIG. And the second corollary CTP is the management after the initial treatment with A, B, and C treatment plans. And this is the only CTP where biologics really do figure in the treatment plan, saying, consider starting a BT-MARD if there's worsening of disease after the 4 weeks of non-response to the initial plans. Very recently, in June of this year, we published the Biologic CTPs, and I'm going to discuss this in a little more detail today. So who is the patient that you should consider eligible for putting on the Biologic CTP through CARA CTP plans? These are patients that are fairly refractory, so they've had prior treatment failure or intolerance to all of the following: pulse or oral steroids. They should have failed at least 1 non-biologic DMARD, and they should be having active disease despite IVIG treatment. Additionally, if you're putting a patient on a biologic DMARD CTP for juvenile myositis, they should be compliant or adherent with their therapy. They should preferably not have severe systemic disease, and they should not have been previously treated with a biologic medication. For the biologic CTPs through CARA, there are 4 options reflecting 4 different pathways for biologic agents. So option A, which is TNF inhibitor, where you can consider either adalimumab or infliximab. Option B, which is abatacept, where you can consider either IV or subcutaneous dosing. Option C is rituximab, which gives you a choice of 3 different dosing regimens, either 2 doses or 4 doses weekly or a single dose every 6 months. And last but not least, option D is tocilizumab that can be given every 2 to 4 weeks. So as we saw, these patients that are really severe or really sick don't really qualify for the biologic CTP. So I'm just going to give you a flavor of what we tend to do at our center with the severe dermatomyositis patients. This is a 16-year-old girl who was admitted in 2022 with about 2 months of severe weakness with a CMAS less than 10, dysphonia, and faint rash. So she had a faint malar rash, erythroderma-like rash of her shins. She did not have Gottron's papules, and she potentially had a B sign. On admission, her muscle enzymes were sky high with a CK of over 19,000. She had mildly elevated inflammatory markers, and she had features of rhabdomyolysis. She eventually came back NXP2 positive, and I think Dr. Wedderburn will be really happy to hear that we actually biopsied this patient right at the get-go because she had very minimal cutaneous features. Her biopsy eventually came back, pretty classic for NXP2 positive disease with areas of multifocal infarcts and regeneration. This graph shows her CK level plotted against time while she was in the ICU because she was impending respiratory failure. The vertical red lines are doses of pulse methylprednisolone. And as you can see here, pretty early on, we treated her with 3 days of pulse steroid, followed by repeat doses of pulse methylprednisolone every 2 to 7 days. She was started on background therapy with hydroxychloroquine, methotrexate, and daily steroids. And within a week, she received her first biologic, which is IVIG. This was given at within 1 week, and then a second dose 2 weeks apart, followed by monthly dosing. She continued to deteriorate clinically, even though her CK was dropping with progressive weakness, bulbar involvement, and eventual respiratory failure, as a result of which we treated her with 6 doses of IV cyclophosphamide and 2 doses of rituximab given 2 weeks apart. Even with this aggressive therapy, she continued to have complications, including cardiac arrhythmias, fever, shock requiring pressors, gut vasculopathy, and respiratory failure for which she was intubated. And lo and behold, the poor little girl also developed macrophage activation for which we treated her with anakinra. So you can see in somebody as severe as this, we treated her pretty aggressively with 3 different biologic agents within the first 6 to 8 weeks of her admission. And this is really what helped stabilize her course and get her off the ventilator and off the pressors eventually. So moving on to the third question, which BDMARDs are on the horizon for myositis? I'm only going to talk about one BDMARD. This is an anti-interferon beta agent, and this data was presented by Rohit Agarwal and his group at the ACR Convergence meeting last year. This was a phase 2 randomized control trial in adult patients with dermatomyositis that either had skin predominant or muscle predominant disease. They gave this agent in 2 different doses as shown here, and it's given IV at 0, 4, and 8 weeks. What is really nice is that these patients showed rapid improvement within 1 to 4 weeks in both cutaneous and muscle measures, thus showing that this agent has rapid onset of efficacy, so it may be really useful in the really sick patients, and not surprisingly, it allowed for a faster steroid taper. With that, I'm going to actually present a few slides on CAR T-cell therapy. CAR T-cells are not really a biologic agent, but they are, I feel like no rheumatology conference these days is complete without mentioning the potential of CAR T-cells. So what are CAR T-cells? These are immune cells that are taken either through the patient or through a healthy donor. They're then engineered with the CAR gene, either through virus transduction or gene editing, such that they express the chimeric antigen receptor. They're made to undergo ex vivo expansion, and then they're reinfused back into the patient after the patient has had a course of lymphodepletion, usually with fludarabine and cyclophosphamide. This was looked at in adults. So CD19 CAR T-cell therapy was looked at in 3 or 4 adult patients, I believe, now with anti-synthetase syndrome. And what's nice about this particular immunotherapy is that these adults were very refractory to therapy. So they'd been on steroids, they'd been on previous B-cell blocking agents such as rituximab. One patient had even been on ocrelizumab. They'd been on a multitude of drugs. After they received lymphodepletion and 1 single dose of CD19 CAR T-cells, about 150 to 240 days out, these patients really were in drug-free remission. One patient had to start low doses of azathioprine and MMF because certain T cells started entering the population again. So they really seem to have potential, but the caveat is this is just case reports yet. And when I looked at the literature, the Italian group has just published a case report on CD19 CAR T cell therapy in a 12-year-old Ukrainian kid with very refractory juvenile dermatomyositis. This patient had ulcerative skin disease for several years, extremely severe myositis, and calcinosis universalis. He'd failed treatment with a ton of steroids, including oral and IV pulses. He'd failed MMF, hydroxychloroquine, IVIG. He'd had 2 rounds of several cycles of plasmapheresis. He'd had 2 courses of 2 doses each of rituximab, and he'd had 6 months of cyclophosphamide. The vertical line here shows when he received the CAR T cell infusion, and you can see in panel B, his skin dramatically responded. In panel C, his myositis dramatically responded on MRIs. And they note that while his calcinosis improved, it did not resolve completely. Various measures, including physician global, CMAS, cutaneous activity measures, and interferon scores, including CXCL9 and CXCL10 as well, showed significant improvement. He did have a few adverse events, including mild cytokine release storm, which it didn't appear that they needed to treat that with any tocilizumab. He had transient anemia and neutropenia. However, what is encouraging in somebody who was as refractory as this patient is that as far as 6 months out, he continues to be off all medications. They also looked at B cell populations reappearing in the periphery through flow cytometry and in the bone marrow as well. And as expected, there was a period of B cell aplasia, and at about 8 weeks, they had certain populations of B cell repopulate in first a transitional population followed by a naive population. However, even though these naive B cells repopulated, his clinical remission persisted and he has continued to be off all medications, thus showing that CD19 CAR T cells potentially are a much, much better version of B cell blockade compared to CD20 agents, allowing us to reset the B cell compartment or reboot the B cell compartment and eliminating pathogenic autoreactive clones of B cells. So what do the experts do? I phoned and emailed several friends across the centers of excellence in the US and asked them, where do they use biologics? How do they use biologics? And while there was some variability, I would say there was also some agreement on what people are doing across the different centers. So for patients with active non-severe disease, pretty much everybody treats it with a combination of methotrexate, IVIG, hydroxychloroquine, and steroids. And if they still have disease activity despite this, or you are having difficulty tapering steroids or toxicity of steroids, many are favoring rituximab early, particularly in autoantibody positive disease, as evidenced by the RIM trial data. Others are considering either abatacept or tocilizumab or adalimumab. What's nice about abatacept and tocilizumab is that they can be given with the IVIG monthly, particularly if there's issues around adherence. If there's comorbid disease present, like psoriasis or IBD, they're considering TNF inhibitors earlier. And then what about severe disease like the patient I showed? Many of us are using very early rituximab, but in combination with therapies that act a little bit faster. So with IV pulse steroids and cyclophosphamide, because rituximab can take up to 20 to 26 weeks to work. If there's concern for MAS, I tend to use anakinra. Others are using tocilizumab as well. For calcinosis, as Adam mentioned, you could consider infliximab, adalimumab, or JAK inhibitors, but the jury is still out onto what really works. And then for interstitial lung disease, I think there's pretty good data, at least from the adult population, showing that rituximab works. And for MDA5 disease, people are using combination with JAK inhibitors. A few other items. I don't tend to use etanercept in juvenile myositis because there's reports of flaring myositis in patients with arthritis that have used etanercept. We tend to avoid IVIGs, particularly if there's a risk for clotting. Avoid rituximab if there's a history of severe, unusual, or recurrent infections. And we avoid abatacept in the MDA5 or calcinotic patients. Most of us use biosimilars interchangeably. Insurance really dictates this in the United States. And I do not recommend using BD-MARDs in isolation. Always use it in combination with other therapies. I believe Sarah, who's on this call, presented the data about PJP infection risk in juvenile myositis. So consider PJP prophylaxis for any patient who's on steroids plus minus BD-MARDs. And last but not least, the Cara Biologic DMARD CTP specifies the toxicity monitoring, which is mostly extrapolated from the arthritis world. With that, many questions remain, and I'm afraid Dr. Google doesn't have the answer to all of these questions, so we need more research with all of the fantastic researchers out there. What is the optimal time for use of biologics? Like many of our diseases, we've shown that there is a window of opportunity. So are we making a mistake using it in the refractory patient? Should we be toppling that pyramid in terms of when and how early we use biologics? Which biologics are most effective in juvenile myositis? Are they better for particular subtypes? Are they better for certain phenotypic qualities? Are there biomarkers to help guide us? There's really no head-to-head or comparative effectiveness studies. Hopefully these will be coming soon through our Cara data. Most of the dosing regimens are extrapolated from the arthritis world. We don't really know what the optimal doses for these agents are in juvenile myositis. And like in the arthritis and IBD world, should we really be thinking about combining biologic DMARDs or biologic DMARDs with targeted synthetic DMARDs? And hopefully someday we'll figure out when is it safe to withdraw these medications in patients that have been in remission. With that, there is a lot of hope. Like I said, I didn't really present a lot of the newer agents that are emerging in the market, but this recent paper published in the Lancet shows you that there are several new therapies that are in early trials. So it's looking very hopeful for our patients with juvenile myositis. I'd like to acknowledge and thank all of the friends that picked up the call and answered my emails. I'm very grateful to have colleagues like y'all across here. And last but not least, would also like to thank the entire group at the CureJM Seattle COE, our physical therapists, Chris and Alex, Christian Lude, Suzanne Edison, who is amazing, our research coordinators, Michelle and Nidhi, and the entire team at Seattle Children's. And I thought we could have a little bit of fun while we were answering questions and just have folks maybe join the Slido and put in their what biologic drugs they have used for the treatment. With that, I will take questions.
Thank you, Susan. Again, as questions come up, could you read them out as you answer them?
Yes. Okay, this question is from Lucy. What are your thoughts on the bispecific antibody TB cell, which may be easier for CAR T cell, as this can be off the shelf? I have no experience with that. I will tell you that from what I've read, it seems to be better, maybe more cost effective as well. But we are just starting CAR T cell at our center, and we're starting it in lupus, and we're having discussions about whether we can do this in myositis. So I think David was on this call. I don't know if he has any additional comments on this question. Thank you, Lucy. Similar discussions. Okay, I don't see any other questions.
If there are no other questions.
I think another question. Yes, please, Lucy, go ahead. Suzanne asked if I will do a talk about JAKs and biologics. Sure. Maybe I can collaborate with Stacy on that. Okay, Lucy asked, how can we move to a time where we can where we all collect specimens in every trial to allow us to move to treatment-related biomarkers? I think that's a fantastic question, and it gives us a lot of food for thought. I really think that from what I'm seeing with the patient population, they are very excited about research. I think organizations such as CureJM are crucial. We are really starting to collaborate across the centers of excellence, and what is needed in these rare diseases is collaboration. So I think talking with CureJM and then really figuring out ways how to collect specimens in every trial and making those specimens available. I think Cara is trying to do this as well across the United States, but it's super important. If you have ideas, Lucy, we're always open as well. Maybe CureJM can insist. Yes, I second that.
For a touch of irony, I was actually on a call. One of the 3 calls I had with Dr. Jessica Tournier today was actually discussing exactly how we can collaborate cross borders on samples and synergize when somebody's looking at proteomics in plasma versus genomics in different cell populations. So the foundation is aware of it. It is on our radar and we are acting on it. It remains for me to thank all the presenters, but I'd like to hand over, if I could now, just briefly for Dr. Jeff DeBergstrom from Duke, just to give a formal wrap-up to today's proceedings. As many of you know, Duke helpers co-host these events with CMEs. And I'll just note and wish Jeff good luck on the weekend, because I think it's the first time in a decade or so that he's actually out competing his horse. So Jeff, over to you and good luck on the weekend.
Thanks, Andrew. I don't know that I can say much more than what's been said about how great the presenters have been, and really some very relevant topics. Susan, the discussion about CAR T cell therapy, is one that's going to be very, near and dear to us here, I think, in the future. But the other thing that was really evident from this symposium was just the level of participation, great questions. I'm just really encouraged by the that level of participation, the degree of investigation, both clinically and more translationally in JM. And this just gives me a lot of hope that we are making a difference in how we impact this disease. And again, Susan, when you were answering Lucy's question and just about parents participating in studies or sample collection, I think that the parents really feel this, like when we have our family days and we can talk about the things that everybody's doing and the directions that we're moving, that they really get this sense of hope too. And I think that's what this is about. And yeah, it's great to bring everybody together. And I thank CureJM for all they've done also, and everybody else. So I don't think anybody wants to spend too much time listening to me talk. So that's my wrap up. Thank you.
Thank you, Jeff. Thank you all for attending. Thank you again to the presenters. You can contact Lauren for CMEs as we sort through that, and also for links to recordings for this. So thank you and good evening to everyone.